welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. We will be expecting to have our main guest soon. But before we get to start the session, let me just take this time to welcome all those who have tuned in early. And we know that there has been a change of time. Normally in Cameroon, this is Town Hall in the past has been at 7 p.m. Cameroon time. But because of the daylight savings, we now have it to be at 6 o'clock, and a lot of people might not be aware of this change. So this is going to impact our turnout for today. But nonetheless, we expect to have a very exciting session because the topic for today is really an interesting one as always. Brian, good to see you.
Yeah. Thanks a lot, Elvis. It's a great pleasure to reconnect every other 2 weeks to talk about major medical and public health issues back in Cameroon. So I'm really thrilled about today's discussion and the speaker for today as well. I think we haven't really had much conversations around this CKD problem in Cameroon, and it's grown to be more of a silent epidemic that I think it's affecting not only Cameroon greatly, but broadly across Africa, as you know. We've discussed about this in previous sessions here, the epidemiological transition that's going on in Africa, where we are seeing an increasing burden of diabetes and hypertension and other non-communicable diseases. So I think that's and those are major risk factors for CKD. So I think there is a great need for us to have an increased attention to this problem and talk about screening and early diagnosis and everything that needs to be done. So I'm really looking forward to this. Been looking forward to hearing Dr. Gobina talk. He's been a renowned nephrologist in Cameroon, someone that I have personally looked up for several years. So it's really an honor for us to have him here today. So Elvis, over.
Yeah, it is really a very big shift and transition in epidemiology in Africa, as you rightly mentioned, for non-communicable disease, and also globally, because there are about 850 million people globally that are suffering from CKD. And it's always known that 90% of people with CKD don't know they have it until when they need to see a nephrologist. So this is a very important topic. And if you look at for the past decade in Cameroon, you look at the number of dialysis centers keep increasing. The government keep creating more dialysis centers, but despite this, they still have number of patients who have to wait for long to get their session because they said all the centers are overwhelmed with patients. And so this is just an indication that as the years go by, the number of people needing to be on dialysis keep increasing. And that's a big signal to us that something is really going on that we need to address. And as you rightly mentioned, early detection might be the way, as we are going to hear today from our guest speaker, Dr. Ronald Gobina, who is a nephrologist at the Boya Regional Hospital. So we hope that he's going to tell us firsthand what the situation is in Cameroon. I know we have some other regulars in the hall, and we want to know what their thoughts are on this topic while we wait for Ronald to dial in. And I see Dr. Brown-Hida is already tuning. I know she might be busy.
I found out that a lot of the information that they shared with me was actually wrong information.
Okay, so hi, Dr. Brown-Hida. Good to see you. And
yeah, sorry. Hi. Hi, Elvis.
Life changing.
I was a little bit distracted, so I'm glad to join today. So I am very, I think it's a very important topic, like Brian said, with chronic kidney disease. Unfortunately, there's still a lot of need back home. So it will really be good to hear what Dr. Gobina has to say. And, we'll go from there, see how what else can be done. Even this town hall, what else we can, if there's anything that we can do to help, because I think one of the goals of having these talks and meetings is to kind of get a sense of what is actually going on back home and how we can help in our own little way to move things forward. So thank you.
Thank you, Dr. Brownhida. It's always a pleasure to have you during these sessions, and your insights are always really, really valuable to the conversation. We have Dr. Pokam Nella. We see you. Any thoughts about the topic for today? Dr. Pokam Onella. Great. We have Dr. Samuel. Hi, Dr. Samuel. Good to see you as always. I know you should be passionate about this topic too, considering that maybe your center in Dub is also seeing some patients with CKD.
Hi, Elvis. Thank you, everyone. This is an important topic. I think many of us will attest that you probably know someone that is going through dialysis or has been through dialysis. And like you said, we are having increasing centers for dialysis. It is really an interesting topic for us, and looking forward to the discussion and to see how can we move forward. What can we do at our own little level to move this forward? Yes, we definitely have a lot of patients with CKD that we usually refer them out because, we are in an area where we don't have any dialysis. So this is a really interesting topic for us. Thank you.
Yeah, thank you very much, Samuel. I agree with you. It's really an interesting topic. And back to you, Brian. One of the things that is really interesting on the topic for today is when I see the word drivers. And we want to really understand what are some of the drivers of the increasing burden of CKD in Africa. You mentioned already that hypertension and diabetes are some of the risk factors, but and also age, of course. But maybe there is some trend that we are finding in the population in Africa where younger people are increasingly getting on dialysis and having CKDs, and we want to be able to think maybe is there enough data that can point towards some other drivers beyond just looking at hypertension and diabetes. What are your thoughts towards this? I know we're going to hear a lot from Ronald today, but I think that aspect of the drivers of CKD is a really important thing that I'm curious to learn from Ronald today.
Yeah, same. I'm also looking forward to hearing Dr. Gobina's insights on really what the key drivers are. And as you mentioned, yes, diabetes and hypertension are known long-term risk factors for CKD that we've seen. But there's an increasing prevalence of CKD in younger populations, as you've mentioned. I don't know what that's attributed to. Is it related to diet? Is it based on what we are eating? Young people, is it substance abuse, substance use? Is it traditional medicines and things like that? So I'm very, very curious. And also the predisposition of genetic conditions as well. I know of a medical student who did their thesis last year, and they found an increasing prevalence of some genetic disorders that was sort of predisposing people to CKD. So I'm not sure what's happening, but my suspicion, Elvis, is this epidemiological transition that we are seeing across the continent is probably somehow intertwined in some way. This phase we are going through, where we are seeing infectious disease and communicable diseases being quickly overburdened with non-communicable diseases. So I think we need very robust epidemiological surveillance mechanisms across Cameroon, so we can really quantify what those major risk factors and some of those drivers are. So I think it's a very complex issue, but I'm really looking forward to hearing Dr. Gobina, since he's been a practicing nephrologist. I'm really looking forward to hearing more about what he's seeing in clinical practice and what he's seen throughout his practice as a nephrologist, on what might really be some of the key drivers around this, and what are some ways that we can mitigate this.
Yeah, I agree with you. While Ronald is setting up his screen, but I mean, you mentioned the intertwine between infectious disease and also a non-communicable disease, and that's one of the call for global health approach, that there need to be some holistic approach on how we look at global health, because sometimes these different units they don't really speak to each other. If you go to present a grant on CKD to PEPFAR, they would say we work only on HIV. But you would agree that the HIV patients on the antiretroviral drug are also at risk of having CKD, and they need to have their creatinine monitored regularly. So there's some kind of an intersection between communicable disease and non-communicable disease. And also, Brian, I read some articles while preparing for this session today where there is also the heat stress, which has been also incriminated for the increasing CKD burden that we are finding across the world. And there are some studies that were done among some sugarcane farmers in Brazil where they were found to have a high level of CKD because of long time of heat exposure also. But I think a lot of those stuff we'll hear from our expert today. But once again, ladies and gentlemen, if you're joining this session, this is a Cameroon Town Hall for healthcare professionals. We meet every 2 weeks to discuss on health issues that impact the public health system in Cameroon. And our guest today is Dr. Ronald Gobina, who is a nephrologist consultant at the Boya Regional Hospital. He's done a lot of work in this space, and he's a trusted authority, not just in Cameroon, but in the continent as well, with so many papers out there and so many professional collaboration work going on between Africa and here in the US. So I think that Ronald is one of those persons that will be able to enlighten us on this topic, which is chronic kidney disease in Cameroon, an overview of the drivers, opportunities, and challenges. So once again, thank you so much, Dr. Ronald, for accepting our invitation to the town hall session today. I'm going to make you co-host so you can be able to share your screen. But I think, yeah, you have the right to share your screen now. And let's see if we can see your slides.
Thank you, Elvis. I hope I'm audible.
Yes.
Recording in progress.
Okay.
You have the ability to share your screen?
Yes.
Okay,
Thank
great.
you. I'll do that right away.
While he's sharing his screen, welcome Franklin Maloba, our regular. Good to see you in the town hall today. We have we have Amy Fon, Raisa Nana. We can see you guys. We want to appreciate you guys for joining the session today. Breeze Nuthe, you're welcome to the session.
Hello, Elvis. I'm not sure I cannot see my screen. There it is. Thank you, Elvis. Thank you to the town hall for having me.
Yeah, it's a pleasure. Yes, you're good.
Thank you. Thank you very much. It's really an honor to be able to share with my brothers all over the world this topic, which is dear to my heart. And I'm already certain that in the time allocated, I will not be able to crush on every possible angle. But it's a discussion, and it's a discussion in progress. So we'll be able to exchange and at least touch on the things that I think are important and have a take-home message at least by the end of our discussion. So I'm going to dive straight away into this discussion. I do not have any disclosures to make. So we're going to follow just a simple plan. We're going to have a look a little bit at what I consider to be the burdens we need to take to heart and the realities. We'll touch on the policies that concern us and the opportunities. There is no chapter on the challenges, but we'll be touching on the challenges right from the beginning to the end, and then we'll make a conclusion. I seem to have a lot of echo. I don't know if you all have the same. So we're talking about chronic kidney disease, and I just want to put this introduction here because it's important for our understanding. So when we talk about kidney function in nephrology, we're not talking about all the functions of the kidney. When we talk about kidney function, we're talking about one function of the kidney, and that is the filtration function of the kidney. The kidney has so many functions. There's the endocrine functions, regulation of blood pressure, so many things. When we say classically kidney function, we're looking at filtration. And how do we check the filtration function, the glomerular filtration function, is through markers like creatinine. Creatinine is the most widely used biological marker worldwide. Now, assessing kidney function is just one arm of looking at kidney health. When you consider kidney health as a whole, you're talking of function on one hand, but also you're interested in every other thing which is a marker of kidney disease. And then you're interested in the kidney size, in the kidney structure, because you can have an abnormal kidney in terms of its structure, but it's functioning at 100%. You can have other markers of kidney disease, like proteins in your urine, but your glomerular filtration rate or your kidney function is at 100%. So we need to put all of that in our minds as we are moving forward. When we talk of kidney failure, therefore, we're simply talking of someone who has reduced glomerular filtration rate. So it's the function that has changed. So that's it. The body, kidney disease, improving global outcomes. Body is the body that has set the definition for chronic kidney disease, and it has been reviewed several times, and it is still being retained. So when we say someone has chronic kidney disease, we're referring to someone who has, you remember the two parameters we looked at, markers of kidney damage or marker of reduced kidney function. So when we talk of kidney function, we want to see a glomerular rate, filtration rate below 60 mils per minute. But for markers, there are so many. There's urine albuminuria, albumin in urine. There are sediment, urine sediment abnormalities, structural abnormalities, and several others. So this is a spectrum into which we try to pick out what is chronic kidney disease. Creatinine alone or reduced kidney function alone does not define chronic kidney disease. But why are we talking about this in the first place? The numbers are speaking, and the numbers are calling us to action. We have the general population prevalence of chronic kidney disease standing somewhere around 16%. And again, it depends on a lot of things we're going to look at. So we will not take the numbers at first value. And then the numbers with the reduced glomerular filtration rate. So their kidney function is impaired at advanced stages. So between stage 3 and 5 out of 5 stages is around 4.6%. So this is Africa. And you can see Cameroon is somewhere in the middle range, 16%. We have these ranges from 6% in the northern parts of Africa, down to 19% in Western Africa. And I must say that these figures really are underestimates of the reality, because what we actually see is really just the tip of the iceberg. But those are the figures we have. But the figures also are going to depend on a few factors. So I don't want to take you into complex nephrology, but it's important to mention that when we use creatinine, creatinine itself has its weaknesses. So creatinine is a substance that comes from metabolism of our muscles. And So we will imagine that the person who has a lot of muscles can have a different kidney function assessment compared to the person who has little or no muscles. The person who has an amputated leg may have a different value of their kidney function from someone who doesn't. So creatinine is not really produced by the kidney. So how do we use creatinine to accurately assess kidney function? That's the challenge. And because of this challenge, a process has been ongoing, has not ended, where we are building figure calculations, algorithms to try to use creatinine and accurately tell the story of what is happening to the kidney. So the early formulas, which we all learned in school, the Cockcroft and Gold formula, which you can actually calculate with a calculator, showed its limitations, especially given that it was not developed with Africans in mind. And it had so much bearing on the weight of a patient and actually the muscle mass. So with Cockcroft and Gold, a lot more people were said to have chronic kidney disease than actually did. So other formulas came into play. The next thing that came into play was the MDRD formula, which, so relatively, just showing on this slide, which is for Cameroon, you're trying to see a proportion that changes from 21 to 13% just because the formula has changed. That's significant. And MDRD also showed its limitations and a lot more work has been done. We now have the CKD-AP and even an update of it, the CKD-AP 2021, which has brought new figures. So with CKD-AP, we are not at where Cockcroft and Gold were giving us figures, but we have also moved far away from where we had MDRD. So the figures are much higher. And what is the thought behind it? We need to continue playing with the formulas because the value we get is going to determine a lot of things. There is a value at which we want to be able to refer you to a nephrologist. If the bar is set too low, we will refer few people and people are going to progress rapidly into trouble. This is one of the main reasons why there's continuous play on the formulas and the calculations. The other one is that depending on your glomerular filtration rate, there are some drugs we're not going to give you. If we give you certain drugs at a certain glomerular filtration rate, the drug could be lethal. We need to modify the dosage of certain drugs based on your GFR. We cannot use contrast medium on some patients because of very reduced glomerular filtration rates. And then there are regulatory reasons in certain countries where in order to qualify to enter a list, a waiting list for kidney transplant, you need to have a certain GFR. So if you are using a formula that gives you a high GFR, you're going to enter the list very late and you will miss your kidney transplant. So people are pulling the equations to their benefit. An equation that makes me qualify for a list is favorable to me. An equation that makes me seen by a nephrologist early on seems favorable to me. But a nephrologist inside is a little bit confused because one person does not have two glomerular filtration rates just because we're using two formulas. We want to go as close to the reality as possible. And it is for that reason that why GFR alone is not the consideration that a nephrologist is going to use. He's going to use GFR, yes, but he's going to use a lot of other information, your history, your clinical information, other laboratory information, considerations of what you have as risk factors. So my approach towards you with a glomerular filtration rate of 50 or 60 will be totally different if you have diabetes from if you have really no other risk factor and no markers of kidney damage in your urine. So all of these things are at the back of our minds. But no matter which formula we use, studies have shown that at least 1 in 10 Cameroonian adults has chronic kidney disease. So when we consider the formula, we're moving from between 1 to almost 2 in 10, but at least 1 out of every 10 persons you're going to meet has chronic kidney disease, and that is worth looking at. Now, the drivers are many. it would appear that chronic kidney disease actually is on a red carpet, climbing to glory if nothing is done. And on these steps, we have key drivers. Diabetes and hypertension seem to stand out in every single study. And it is understandable that if diabetes is projected to be on an exponential increase, its child, CKD, is also going to follow suit. Same thing for hypertension. Infectious diseases at that crossroads with non-communicable disease. I mean, one of the clearest examples is CKD, because we have a lot of CKD, which is a non-communicable disease, occurring because of hepatitis B, occurring because of HIV, and of course, poorly studied, grossly understudied, the role of parasitic infections in driving CKD. We're talking of malaria, we're talking of schistosomiasis, we're talking of filaria, we're talking of so much. We don't yet know what it is, but we see them in our practice every day. It is not yet appearing in enough literature. Obesity is a great driver. And at the top of this stairs, I put non-traditional risk factors with an exclamation, because I imagine that if we in Africa, in Cameroon, were to tell our story 5 years, 10 years from now, we may not have diabetes as the main driver. We may not have hypertension as the main driver. We have our own story to tell. And I heard in the comments at the start, Elvis was making mention to the heat stress and the CKD-U. Each time I look at the definition given to CKD-U, I always shake my head, because in CKD-U, you're allowed to say any kidney disease is of unknown, the U there is for unknown origin. You're allowed to say that if the risk factors are not the traditional risk factors. But I ask myself, traditional according to whose society? What is traditional elsewhere must not be traditional in our setting. So by the time we give strength to what our own risk factors are, in our setting, they will not be non-traditional, and they will take a forefront place in our list of what are the risk factors. So I think it's high time we need some police officers, CKD police officers, to come and start, putting some of these risk factors in jail, but also policing the narrative as to what is behind CKD, especially to make context sensitive conclusions about the real drivers for CKD. We know that there is a large gap between the CKD burden and the provision of adequate healthcare. That is so true. And this gap is, of course, very obvious when you're in the low middle income countries. So Asene is a young Cameroonian, young graduate from University of Boya. And he did this work as a general practitioner, but has written a few papers in the CKD space. And when he calculated the DALYs, the disability adjusted life years, he found that, so grossly in layman term, in 2017, there was this global burden of disease, and there was a team that was assigned to look at CKD. And you're losing about 35.8 million years because of CKD alone. So this is time that is lost due to premature death, or time that is lost because you were disabled by a certain disease. When you combine those two, you have this factor. And CKD has weighed down on us in all the ways that you can imagine. It's killing people, very high mortality rates. Hale and Fuda did studies in the hospital-based setting, and you can see very high mortalities. 1 in 2 persons with CKD is dying from CKD. Kaze et al. Went and looked at other parameters. 1 in 4 patients starting dialysis will die within their first year. Half will die within the first 6 months. And when you have CKD coexisting with hypertension and diabetes, you have the poorest prognosis. We know that this study was done looking at comparing CKD costs and transplant. I didn't bring the transplant figures here, but it's calculated in US dollars, and we can take it down to CFA easily, that a patient pays out of pocket for his care, dialysis care, about 4,600 US dollars a year. Calculate that, you'll have maybe 2.5 million a year. And if you want to break that into a monthly rate, you have the figures. Compare that figures to what the minimum wage in Cameroon is, and you wonder how people even survive on dialysis in Cameroon. It's true that the government pays almost double of that to be able to allow patients to have access to dialysis care. But what is left for patients to pay is still enormous, and this is a huge burden. Families have been crippled. People have lost their businesses, lost their livelihoods, because they are taking care of a child with CKD. So this is that CKDU thing. And look at the definition that they say. The etiology of CKDU is multifactorial, includes genetic infections, rural residents, farming occupations, so many things. But all of these things are called non-traditional. But I want to underline something here: traditional nephrotoxic medications. So when we talk of nephrotoxic medications, the white man is imagining what is produced in the laboratory. But in our setting, in our working conditions on a daily basis, country medicine is bringing more people on dialysis than we care to imagine. I remember having in my dialysis center a tradi practitioner who was on dialysis because of his own medication. And he admitted to it. He actually stopped some aspects of his practice because he was a victim of his own treatment. He continued treating mad people, and when it came to mixing concoctions as a panacea for everything, he stepped away from that. But this is just one out of hundreds of thousands of people we're seeing with end-stage kidney disease because of traditional medications. I don't think that for us, this is a non-traditional risk factor. It needs to take the forefront. I'm going to take a short detour to look at two things which are of importance, and it's important because your assessment and understanding of all the figures really requires that you understand how we diagnose kidney disease in the first place. So there are many parameters in the diagnosis, but I want to bring this comparative view looking at clinical and histologic diagnosis. So the definitive diagnosis of a kidney disease requires histological assessment. So in the continent Cameroon, histologic assessment is nearly inexistent. It's sad to say, but in 2021, kidney biopsy is not yet a reality in Cameroon. Which means that even when we have the desire to push data out there, our data does not have weight, because you're sending out data and telling people that, oh, this proportion of patients have chronic glomerulonephritis. But each time in Cameroon you hear chronic glomerulonephritis, is because the patient has a clinical syndrome. But elsewhere, they have the clinical syndrome plus histologic confirmation. This is missing in Cameroon, and it's downplaying on the strength of the data that we have. Elsewhere, histology is everything when it comes to kidney disease. And of course, you ask yourself the question, we have pathologists attending this town hall meeting. Why don't we have histology for kidney diseases? So classic biopsy, I stand corrected by all the specialists in the domain here, but classic biopsy, when you stain your slides, you want to look at cellular architecture. And the greatest indications in classical biopsy is to look for malignancy. There are other indications, of course, where you want to check, for inflammatory conditions, left, right, center. But the key driver of biopsy, non-renal biopsy, is malignancy. And then you're interested in the shape of the nucleus, you're interested in all those things that want to say, yes, there's change of architecture, we're dealing with malignancy. For kidney biopsy, malignancy as an interest for biopsy is probably only in 2% or 3%. The reason why we do kidney biopsy is not to look for malignancy. And the reason why we do kidney biopsy is rarely even to look at cells, individual cells. We're interested in cell populations. Normal cells may be just in the wrong place. We're interested in the tissue architecture. And the most difficult part of this process is that whereas you can diagnose breast cancer by looking at the slide and looking at the cells, or lymphoma, to give an accurate, complete diagnosis of a kidney disease, you need 3 things: microscopy, immunofluorescence, and electron microscopy. In the absence of at least microscopy plus immunofluorescence, just few diseases, kidney diseases, can reach the place of a certain diagnosis. Electron microscopy is not commonplace, even in the developed world. So we're not going to blame ourselves because we don't have electron microscopy. But in the absence of immunofluorescence, microscopy alone is a problem, and it's a huge limitation. And so you usually subspecialize in renal pathology before they can read kidney slides. There have been efforts to try to get someone in Cameroon dedicated to doing renal pathology, and that has been a challenge up to this time. And so Cameroon is not the only one having this problem. You have a systematic review that looks at data for 34 years in Africa, and only 13 countries were represented in this data. Let me give you one of the disqualifiers. One main disqualifier was that you should have done at least 50 biopsies. So we're saying that in 34 years, only 13 African countries had done at least 50 biopsies. That is crazy. And 70% of all of this is the culture of the Northern African countries to do histology to confirm their diagnosis and build a database to characterize the type of kidney disease that they have. So for us to catch up in Cameroon, we need to change the narrative, but also other African countries are lagging behind. We need to join in and start. Then we can have figures that will join some of these systematic reviews. The next thing I'm going to jump to as a detour is the treatment. We know that treatment is limited and almost absent in some settings. We have about 30 nephrologists for 30 million population in Cameroon. That's 1 nephrologist for 1 million persons. Again, this is a burden too big to carry. We have limited access to care, limited access to hemodialysis because of cost. But even when you have all the money in the world, geographical accessibility is a huge issue. So I work in Boya and I receive patients from Mundemba with end-stage kidney disease. And sometimes we make assumptions, but not everybody has a family member in Boya where they can go and squat and receive treatment for the rest of their life. You're asking for this head of a family to rent a new house or build a new house and move so that he can acquire care. It's impossible. We need to start to decentralize care, but then that's a challenge for government and everybody. We are still playing with dialysis when dialysis in most countries is just a transitory treatment preparing you for kidney transplant, which is the definitive renal replacement therapy. Where possible, kidney transplant should replace dialysis. We are only now warming up to the idea in Cameroon. We're getting there. Peritoneal dialysis as another type of treatment is totally absent for adults in Cameroon. There are small initiatives that have started peritoneal dialysis for children, but only for acute kidney injury. So in the chronic kidney disease space, peritoneal dialysis is completely absent. These are the figures that show availability of dialysis centers in Cameroon. in the world. And you can see Cameroon in red. So we have 1 dialysis center to 6 dialysis center per million population. We are way down here. We're doing a lot. I must commend government for that. But compared to what is available in the world, we are still taking the last position. 51% of those who need dialysis in Cameroon are going to get it. That's 1 in 2. And up to 84% of patients who are going to start dialysis will stop after just 6 to 7 sessions. Now, 6 to 7 sessions is about 1 month of dialysis. And the reasons for the dropout are multiple. Many of them within this 1 month reach financial exhaustion because a lot of people are so desperate for healthcare that when they come and the doctor says you need this, they sell everything. Then they cannot eat. They cannot even afford transport to come to hospital. And they are going to naturally drop out, get lost to follow up. Over 90% of them are presumed dead by that time. This is horrible. We need to change the narrative. When it comes to treatment, for you to have dialysis care in Cameroon, that's what we offer. We need to have a way that we can connect you to the dialysis machine. So you have catheters that are used for that, but the definitive vascular access for dialysis is what we call the arteriovenous fistula. Arteriovenous fistula surgery is possible in the southwest, in the littoral, in the center, and in one of the northern regions. You can have it in Garo. And we're not even talking about an availability in the regions per se. It's 4 towns. It's Yaoundé, Douala, Garoua, and Boya, where you can have this surgery. So all patients in Cameroon have to, find a place to go get operated. And when you have a failure, you have to move again with all the risks that are borne by patients on dialysis when they have to travel. Now, when you have this fistula surgery that is done, and there is some level of this failure or difficult function, you need to have an assessment. And this assessment usually will go through imaging. You need to do fluoroscopy. Now, Cameroon is boasting of a fluoroscopy cardiology interventional procedures that are done. And the nephrologists in Yaoundé are now borrowing the fluoroscopy suit to be able to do some assessment for patients. But here we have the most important post-access creation assessment existing only in 1 region and only as of literally 2021, 2022. We need to see more of this. And even when you're able to have this imaging modality performed, you need to have, there are basic interventions where elsewhere out there, 15 minutes, you have sent in a balloon and you have angioplasty, somebody's stenosis, or you have taken a clot out. We are unable to do that in Cameroon at this time. And you have people who move in towards access desperation because basic things are not able to be done. And then you have out-of-pocket payment for everything else outside of dialysis, which is subsidized to some degree. You have to pay for your medication, pay for your transportation, pay for your hospitalizations, and everything else. So the burden is huge. The limitations are so many. But Cameroon is not doing too bad, considering what is possible elsewhere in the world. Not every country, even the developed countries, offers subsidies for dialysis care. And not every country has done what Cameroon has done since last year to be able to make dialysis care literally free of charge, but for a 15,000 francs registration rate. So public funded initiatives of free at the point of care in Africa stands at just 34%. And Cameroon subscribes to that number. kudos to the little work that is there so far. Policy is everything in healthcare. If policy can drive initiatives, then you have a marriage between the technicians who have the know-how and the funders, be they government or private, to make sure that the best actions are taking place. And when it comes to policy usually is not automatic. There is always a story behind a politician taking a certain decision. An interesting thing when it comes to a lot of care, which is relatively complex, is that until the thing touch you or touch your family member, is usually not your issue. And we are happy, however it happened, that the problem of kidney disease requiring dialysis touched our politicians in Cameroon to the point that we could have initiatives. And as early as 2007, the order was given to create regional hemodialysis centers. And as of when Bafoussam and Gaoundéré had their centers operational last year, we now have all regions in Cameroon manning a hemodialysis center. And of course, the bigger cities, Yaoundé and Douala, see a need for rapid decongestion. So Yaoundé already had the University Teaching Hospital Dialysis Center and the Yaoundé General Hospital Dialysis Center. And we have been waiting for so long for Douala to also have its decongestion. La Quintini Dialysis Center opened, and there is a huge sigh of relief that has come. And policy also has helped in terms of accessibility, because treatment as of until last year was subsidized, and the cost, which overall globally is about 70,000 francs. Patients were expected to pay just 5,000 of it, but 5,000 twice a week puts you at about 60,000 francs of payment every month for dialysis care, excluding what you will pay for transportation, to feed yourself, to buy your medications. So you find a dialysis patient spending between 100 and 200,000 francs, depending on their comorbidities for dialysis care. So 50,000 francs in a country whose minimum wage used to be around 34,000 francs is still huge. And the government has gone one step further to make dialysis care free of charge. So 5,000 francs is gone. It's another dynamic that has been started, and we'll have to answer for that at some point in time. But it takes a lot of courage to take that decision. We welcome that. Patients are experiencing at least some level of relief because of this action. I was going to add a slide to show the dialysis providers worldwide. When we talk of the top 5 or top 10, there are 2 names that you will find in every report, no matter which you look at. Fresenius Medical Care will always be on the list. B. Brown will always be on the list. And machines. And the initial dialysis centers in Cameroon started with Fresenius Medical Care Centers, and we're privileged to see the robustness of this machine. So policy seems to have gone, at least to some degree, in the right direction in getting the best type of care for dialysis when dialysis was introduced in Cameroon. But policy has its limitations. On board, you will not have perfect policies, but at least you will avoid missing the track more often than not. So in 2023, we have an interesting phenomenon, which in one sense is trying to answer some serious problems, because we have more nephrologists. The side effect of having more nephrologists, more people in nephrology care, is that you have more diagnosis. You have more diagnosis, you're going to identify more people who require dialysis care. You identify more people, you need to have more rooms for them, more space for them, more treatment capabilities for them. And the government is responding to the cries. Every single dialysis center in this country has experienced a situation where the capacity they had was inferior to the demand. I experienced it in the biggest centers during my training. And the nephrologists found themselves in this frustrating situation of having to rationalize dialysis care. Elsewhere, people receive dialysis 3 times a week. In Cameroon, we offer it 2 times a week. And we have found ourselves in situations where you cannot offer 1 session per week to a patient. Some centers just lock down, they don't take any new patients. Some centers, I remember one of my fathers in nephrology in Cameroon, he will always say, if I lock down this center and one minister's cousin appears here, I'm going to open it out of pressure. So I will not lock it down. I will keep the center open and take one after another as they come. Wherever we end, we end. But everybody has reached that place where you see people waiting in the dialysis center for 2 days, 3 days for their turn, only to receive a suboptimal dialysis because they will not even get 4 hours, they'll get maybe 3 hours. And instead of having 8 hours in a week, they're going to have 3 hours for 2 weeks. You know that you're just curing their mentality and calming their nerves, but you're not treating them. So what is happening? Now we have more centers being opened. There are initiatives to open at least 1 more center in every region. So the regions will move towards 2 or 3 dialysis centers in a very short time. Before that happened, a lot of centers have experienced an expansion in their number of machines. And the expansion has happened in its own nice way and sometimes in its own challenging way. So I give the example of the Boya Regional Hemodialysis expansion. All the new machines are of a different brand to the machines we had before. No publicity intended and no downplay intended either. But this is what happens, is that the new brand comes in with conditions. One of the conditions they set is that we will bring our machines, but we will not connect our machines to the previous setup. We need our own circuit. So what do I mean by previous setup? And the military hospital in Yaoundé learned this the hard way, because a lot of people thought that dialysis was about dialysis machines. So they get donations of dialysis machine. Dialysis machine cannot do nothing. The dialysis machine is the last point in the dialysis circuit. That machine is supposed to mix a certain number of solutions with specific concentrations in certain chemicals to produce a final solution with a specific concentration. That's the work of that big machine called the dialysis generator. And one of the ingredients to produce this final solution for dialysis is pure water. As in chemistry, H2O, nothing else added, nothing diluted inside, no virus, nothing. So a dialysis center has, at the start, a water treatment room. And you had an embarrassing situation in Yaoundé where the military hospital obtained dialysis machines, called the media. There was a whole ceremony on TV to inaugurate it. And after all the eating of chicken and soya, patients came and said, dialyze us. And people then realized that we cannot dialyze because the machine was nothing. There was no water treatment room. You know, consumables are not present. You cannot dialyze without these. So you need a water treatment room. And what is a water treatment room? It's a whole circuit of small equipment that produces pure water in the end. And you have a new dialysis brand that comes in and says, my machine cannot take your own pure water. I need to set up my own water treatment room. So if somebody is to do the study, you will find many dialysis centers in Cameroon now that have multiple water treatment rooms. This is, in my opinion, my humble opinion, not a very wise use of taxpayer money, because the water treatment room have only one specification: I can produce pure water. The next question you ask is the reverse osmosis machine. That machine that has produced the water, what is its capacity? You have machines whose capacity is 20 machines, 20 dialysis generators, or 30. Irrespective of the brand of the dialysis generator, as long as you are below 30, that water treatment room can carry. But of course, if I don't put my own machine, I can, it's like a little bit of blackmail, because if anything happens to my machines while I'm using your water treatment room, I can blame you and I will not keep our guarantee. So we have twin centers in one center. And depending on who is sitting on the bench for maintenance of machines, one center can actually close down. That's our actual experience. All our old machines have been relegated to the background. Efforts at central level to fix them are fruitless while the new center is running. And that's not how we should move. So we're seeing many more brands coming in. It's good to diversify. We're seeing even the newer brands are still the top brands, but we need some small level of sanity in how we're going to do with all of this. And then you have the consumables. The first providers came and said, oh, my machines are not compatible with these other consumables. And they have been proven wrong. The ministry took the bold step of getting some of them generic consumables, and we realized that they work perfectly well in the Cameroonian market. So some of these things have been opened, and we are seeing opportunities that more people can have access to dialysis care, hopefully at a cheaper cost. That we have not yet seen. There are a lot of opportunities in this space. There is a changing landscape of CKD in Cameroon, and we need data to clearly characterize what is going on. Without data, we cannot develop interventions to limit the incidence or to slow the progression of chronic kidney disease. There is a solid cry for generation of data. And remember the previous slides. As long as we generate data without histologic confirmation, we are still moving in reverse gear. So some of this data has to only pick up weight when we are producing data with the standards that is expected, at least for 2024. There is a need for research. A lot of what we are using as conclusions are projections from what has been reported elsewhere in the world. We need to start to tell our own story with a lot of confidence. There are opportunities in the CKD space. Healthcare is a huge business magnet worldwide, and Cameroon is no different. And the call will continue to go out there for business people. Come and set up a pathology lab that can do kidney biopsies. All of Cameroon will send samples to you. We do not have this. There is room for private dialysis centers. South Africa has one of the, in sub-Saharan Africa, one of the best, programs in dialysis care. And 80% of all their dialysis centers are in the private sector. The private sector is a necessary evil and a necessary good. There's you see evil in that it will bring good competition with state centers. But personally, the one area where I have appreciated private centers the most is that when state institutions meet setbacks, crumble because of A, B, C, D, E, delay in ordering consumables, and machines are not repaired, no preventive or secondary maintenance taking place, centers shut down. A few people stay alive because there are private centers in Cameroon. We need more. If we have a few more, some of the deaths that we experience are going to reduce, because I can imagine those who can afford, who will go for their third dialysis sessions in the week in a private dialysis center. Their lives will be totally different if they can have just that one added dialysis session in a week. In Cameroon, we are able to train nephrologists. So we have locally made nephrologists for our own local realities. But I was trained in this setting, and I must say that after visiting nephrology training centers outside of the country, I look forward to us coming to more solid partnerships for exchange programs, for twinning in training, because some of the exposure that is possible out there can really change the narrative about the skill set that our Cameroonian nephrologists are able to gather. There is room to improve on specialty care services. So dialysis is not everything. Creating a dialysis fistula is part of interventional nephrology. Creating or placing tunnel catheters, doing kidney biopsies is part of interventional nephrology. This is my passion, and I want to see interventional nephrology developed in Cameroon and decentralized to the degree that is possible for our country. But forgetting that, you cannot do interventional nephrology, but you have a solid psychosocial support organization where you can come and create interventions for the mental health of dialysis patients. Come in, set up shop, and let us work together. Or you have a solid dietary program which can be adapted for dialysis patients. We are looking for people to pick up these opportunities and come. And of course, you will make a living just by doing this. There are opportunities for sponsorship. And I love this because we have seen remarkable things. People have been out there and they have called, "How can I help, doctor?" And we simply tell them, there is this 8-year-old, 9-year-old child who needs an adoption. And we've had people adopt children on dialysis in Cameroon, literally change their lives because they are able to have their dialysis care without stress. They can go to school without stress. We have 5 papers, 11 papers, GCE, among these people simply because somebody was there to hold their hands. And we continue to sell this as a model that can work. You may not be able to change the policy and build a dialysis center, but pick up one child and send them to school who is on dialysis. That can happen. We have sponsors that have come to help people with vascular access. We have people that just come as a group. I just want to bless your dialysis center, and they release a sum of money, which we allocate to the needs of the patients in different ways. Another observation I'm beginning to see, and it is disheartening, and I hope that the audience here can help to advocate for the opposite, is that when patients were paying dialysis before universal healthcare, 5,000 francs a session, it was more commonplace to have organizations come and drop 100,000 francs. And so 100,000 francs will be 20 dialysis sessions. So 20 dialysis patients can say, "Thank you, NGO X." And they love that because this is selling points to help raise funds, but also it's a feel-good thing that 20 dialysis patients can appreciate you for one session. I've had a few calls from people who did not know that dialysis care has become free in Cameroon, and they wanted to help dialysis patients. And they were using the old narrative. "Oh, we want to pay, we have like 150,000. We know that it can pay for for 100 dialysis sessions for so many patients. And I'm like, oh no, right now dialysis care is free. So, but if you have that money, you may not be able to pay for dialysis sessions. You can do other things. We can direct you towards somebody who is really struggling to help them start a business, or someone who is struggling with dialysis access and needs a dialysis fistula. And they're like, oh yes, let's think about it. We'll get back to you. And they never call back. They would rather go now and do something else, buy Savon and distribute, and actually have 20 people say thank you. I don't think that this should discourage people from helping. And people may need to warm up to the idea that having an impact on one life sometimes will mean more than giving 30 people one dialysis session. I would like to see the courage that will be taken by organizations to choose one person and set them up for longevity in dialysis. I'm not just want to come and do surface. I'm not insulting, 5, 10 dialysis sessions for 10 persons. But after one dialysis session is done and the thank you is given, they have a lifetime to live, and the impact is not as much. So it's a cry. What do we need? We need to be rational. In a few words, I was trying to explain and describe how dialysis centers are being multiplied in Cameroon. I would love to see more rationality, and I'm hoping that the public powers that be would consult with the a lot more sense than putting one dialysis center in Boya, one in Kumba, and one in Manfred. Because we have dialysis centers in Cameroon that cater for 20 patients in absolute luxury. These centers function practically 4 days in a week. And on the days they run from about 8 a.m. to 2 p.m. I'm talking real dialysis centers, because their numbers compared to the numbers of machines allows them to do that. They have 3 days off a week and only attend to emergencies. Whereas you have other centers running 24/7 and struggling to even give people 2 sessions a week, which means that in the allocation of machines per region, rationality wasn't at its optimum. And it's important to take that as lessons when we're trying to multiply the centers. Rather than give the Southwest three centers, we need 2 maybe. Give 5 to the littoral and 5 to the center region. We need to be rational. We need to be rational also in the costs. The mercurial system of Cameroon, God help me not to say something that I should not say, but it may serve its purpose, but to me, it seems like a commitment to achieve less with more. Because if it is possible to have dialysis kits somewhere in the world for 20,000 francs a kit, or 10,000 francs a kit, the mercurial system obliges you somehow, it seems in the way it is being used, to rather say, yes, you can sell it to us you can sell a bag of cement to us at 6,000, but I want to buy it at 20,000. That's what mercurial actually says. And if we end up spending 40,000, 60,000 on a kit, which is possible to be gotten and delivered at the center at 20,000, we are preventing the double from being available to our dialysis patients. It's a call for conscience, especially when it comes to policy in the healthcare space. You may work in building football stadia, but in the healthcare space, it's going to cost us a lot. We need to be responsible. We need to be bold. We are already doing a lot in terms of boldness, engaging universal health coverage, inviting people to come for care despite your limited resources, inviting people to come and overwhelm the human resources. 30 nephrologists for 30 million people is being bold. And our last step of boldness, which is a joy to Cameroonians, is that we have started doing kidney transplants in Cameroon. Kudos to the government. Kudos to the director of the Yaoundé General Hospital, who, in spite of all the discouragements that were coming at him from every angle, said, I'm going to start. He started and has recorded success stories. We need more boldness to engage all the responsibilities that stand ahead of us. We need to do wise spending. Quality has a price tag, poor quality as well. If we can spend all that we are spending and we get the top-notch quality, top-notch centers, that is going to be the dream. But anything less than that for the level of spending we're doing is going to break the moral fabric of the team that is offering care to dialysis patients. We are making strides already. And I will conclude on saying that the burden of CKD in Cameroon is high, but it remains grossly underappreciated. It is possible, if we look in closely, we are not in 1 in 10 Cameroonians. We could be in 2 in 10, maybe 3 in 10 Cameroonian adults with CKD. Concerted action is required to tackle the risk factors and drive the burden down and not upward, with the trend that diabetes and hypertension and obesity and infectious diseases are taken. We need to put the brakes on the acceleration of chronic kidney disease. Government seems to be on the right footing in so many areas, but needs a lot more huge leaps to be taken. And for those of you who have a voice that can be heard by the government, tell them that they are being congratulated to the highest degree. They are highly appreciated by the patients who have a smile on their faces, but tell them that there's a lot more they can do. And if they will listen to the technicians, proposals can be made for optimizing CKD care at all levels: prevention, screening, diagnosis, and treatment. Thank you very much for your kind attention. I'll hand the floor back over to the moderators. Thank you.
Wow. Thank you very much, Dr. Ronald Gobina. Thank you. This has really been an amazing presentation. Brian, I've not stopped writing since he started the presentation, and writing and sweating at the same time, because it's really, really amazing to listen to Ronald Gobina. This is one of really best session I've had. Really, the style of Gobina, right? He takes us to a roller coaster of emotions, right? Painting the situation, takes us to a high level, and then brings us down, then takes us up. But the good thing is that he ends with a positive way that reassures us that there is hope. It's kind of a style of presentation I've not seen before, right? At some point, I was feeling low emotionally. At some point, he takes me back up, and then he ends in a way that I feel that there is something more we can do. Brian, what's your take about the presentation?
Yeah, thanks, Elvis. I totally agree. Excellent presentation, Dr. Gobina. Really great in-depth presentation. I think the presentation was a major call for action for stakeholders, and he highlighted, I think, some of the key issues in Cameroon, which I hope we will have a chance to interact with during the Q&A. I think our goals from his presentations are really clear. What do we do in order to, we have to reduce the incidence of CKD. We have to improve the quality of care. I think that's one thing he highlighted in his presentation as well. Those who have been affected, how do we improve their quality of care? And also, how do we really forge a future where this problem is much lower? So I think it was a really great presentation, in-depth presentation, and thanks a lot, Dr. Gobina. Over to you, Elvis.
Yeah, Brian, before I bring it back to you for the question and answer session, let me just get to Muno. Muno, you are one of those persons, our chair, who is always very critical about, how science is being driven by Western agenda and what our own interest as African is. Something that stood out to me was that the semantics that Ronald used about traditional risk factors or non-traditional risk factors. And he said that this semantics of non-traditional does not fit well with him, because it's been coined out by people in another region where those things appear to be non-traditional for them, but in our context, to him, they are traditional, because if you talk about medications, auto-medication, you talk about herbs that people use, traditional medicines, and all those other heat exposure and stuff that are referred to as non-traditional. To him, he thinks that language does not speak well to us as African. What's your take about the way and he also demonstrated that even in the definition of a CKD and the different equations, and how the politics around the use of this equation is being, pulled to the strings of who really needs this equation to favor their interest. Mona, I just want to hear what your take is about the presentation entirely, and maybe some comments around this issue of contextualizing science.
Well, Elvis, thank you. I'm sorry I'm on call, but Dr. Gobina always gives a masterclass presentation. So this was one of those masterclass presentations where you get to understand what is really happening back home, which we need, and also propose solutions, and also highlight the strides that they are making also back home, because there are a lot of good things happening. I have always said there is an old adage, you understand, the tortoise always wins because the person who wrote the books always considered the tortoise as the wise guy. I don't think every other animal, if they had written their story, the end is going to be different. So Elvis, you know what I always say, if you take how many studies included Africans in developing all of these formulas, maybe now we're being included, how many studies? I always say in cancer, you cannot really generalize studies that were done in populations that were Caucasians mostly, hardly Africans, and think that you can use those things in order to help us or define what we are having. So once we start writing our own stories, we start doing our own research, then we'll start understanding, as Dr. Gobina is proposing, what is really happening in the CKD phase in Cameroon. And there are many factors that to us are regular factors we see every day. So I've been in and out, but learning, really that's what I've been doing, learning. And I did love one part of his slide, which is something I've advocated for a very long time in Cameroon. Before leaving Cameroon, I did clinical pathology. There is one big gap in our care, is that we do not value the work of the pathologists. Neither are the pathologists even trained to be able to help us in what we need in order to care for our patients. It's not, even in cancer, as they say, pathology is oriented towards cancer. It's not in Cameroon. It's so sad that the basic things, and you can't even get it to treat a patient who has even breast cancer. If you cannot do immunohistochemistry, how do you get to do immunofluorescence? How do you even get to the point where you can even get in situ hybridization, where you can even get electronic microscopy? It gets to the point where we are still very rudimentary. But I love his presentation because it was very, how do I call it? It was very positive at the end. We saw things that we can do where we can help. So I know, he has never failed us. So Gobina has never failed with his presentation. So this was a master class presentation. That's all I can say.
No, thank you very much. And when he talked about the issue of absence of histology, somebody wrote on the comment section that Mona always said, no tissue, no issue. I think the more we get that your quote circulated around, people understand the importance of getting this as part of the plateau technique that we need in Cameroon. And one of the things he said was, and I'm going to talk to Dr. Samuel about this, is, and I'm giving Ronald some time to drink some water before I hand it over to Brian. No matter the equation you use, no matter which language you use, the underlining take home for me is 1 in 10 Cameroonians have CKD. And he also mentioned that in a population of 30 million Cameroonians, you have 30 nephrologists. So 1 nephrology for 1 million people. And if you use that equation of 1 in 10 Cameroonians have CKD, it means you are talking about 10% of 1 million people, right? So in that case, it means you are saying that 1 nephrology is able to take care of how many patients? 10,000 CKD patients for 1 human being who has to work for 40 hours a week. I want to ask you, Samuel, what are your takes about this, and what is it that you think can immediately be done to meet this gap in terms of human resource? Because I know he mentioned also at the end the need for private investors, private sector engagement, and you are one of those who have a clinic in Cameroon. What do you think we can do?
So again, I want to thank Dr. Gobina for the excellent presentation. It was really insightful. Most of the areas and even questions that we have, you answer many of the questions. And I think when you talk about the private sector, it is actually an area, the way you presented it. And I believe even also the call, especially for those of us in diaspora, what we can do. Sometimes only the criticizing without looking for a solution, or without coming like, what can we all do? I think you have helped us to understand that it is not only bringing dialysis machine. You know, I've been having a lot of calls. Oh, we have dialysis machine here, we need to bring them to Cameroon. I think that with the current working plans that we in diaspora, and also I want to thank Elvis and the town hall, it would be to look forward to actually continue to advocate with the town hall, with the working group. We are looking for more sessions to see how we can give the opportunities for those who really want to invest. Having professors like you, I mean, it is really the needs are there. And looking at that, you have 30 nephrologists to 30 million. Elvis, I actually had a question to that. And that we have an institution now, we have a lot of providers and professionals outside where they can also be of help, especially training the support system. He talked about a specialty services. How can we, in our own little way, I believe that we can actually do something right now. I mean, he is available. If you look at only training, we were talking about nephrologists. How about the technicians? How about those who work with him in order to make sure we provide this service? What can we offer now? Like he is saying, yes, it's actually possible. Part of the solution is that if we have a plan in place, Dr. Gobina is available. You can help train one technician. And that was where my question, I was going to direct that. We do have curriculum for the nephrologists. Do we also have curriculums and training for the support system? Because I know you have in your office, you have all this at the front desk, you have those running machines. So Elvis, the first part of your question will be that I will be really advocating that in the town hall, we can right now do things to support the current system. We now know we have dialysis center in each region. How can we contribute in the training, in providing support for those support staff that are working with Dr. Gobina and other nephrologists? That would take a lot of burden to begin with, because we can look at what we can do right now and then start working in proposing policies that can help improve to bring in more investors in the private sector. So thank you. And if it is okay for me to ask that question, I can go ahead and, like I'm asking, do we wait for questions time or?
I think you can ask your question, and Brian will forgive me for giving you that floor. He will handle that soon.
Thank you very much. Thank you. So yeah, to that question about, we do have a curriculum for training nephrologists, but why do we still then have only 30 nephrologists to that number? Is it that the criteria for graduating nephrology, is it so stringent if you already have the curriculum? Number two on the question will be the support staff, like technicians. Do we actually have training curriculum for them too? Thank you.
Yeah, thank you very much, Dr. Samuel. Your thoughts are always very insightful, and we really appreciate your comments and contribution. Before I hand over to Brian, I would say that we are going to run a survey in the town hall. We launched a Give Back project where we ask all town hall members to do something in their community, wherever they identify with in Cameroon, and report to the town hall for appreciation by the Minister of Public Health. And Brian and I and the other team of the moderating team has been working hard to bring to you the digital platform and the templates that you need in order to report your project. And I know a lot of people are doing projects already. All you need to do is report it so we can have visibility of that at the level of the town hall. We are going to run a little survey, so you'll watch out for your email, where we'll be asking a question for all of you to just answer and tell us if you have any work that is related to CKD. If you are a nephrologist, you identify. If you are a nurse, you identify. If you are anybody that is doing some work there, we want to be able to measure our own capacity at the level of town hall. We are 2,350 participants of this hall. We want to know those who are directly implicated in CKD care, so we can now start talking about who can do what in this space back home. Brian, before I give over to you the microphone to handle the question and answer, I want you to know, Brian, that globally, water use for hemodialysis is about approximately 265 million metric tons per year. And this water is represented by reverse osmosis rejected water discharged into the drain. Just so you know that dialysis is not just about equipment, as Ronald said, it's a lot to do with clean water, the H2O as defined. And I want you to take that into your question and answer session and get the thoughts of what people think when ordinary Cameroonians lack H2O to drink, talk less of to dialysis. Over to you, Brian.
I agree. It's a very complex problem intertwined, and I think we've seen how multidisciplinary the management of CKD can be as well. So I just want to highlight, if you have thoughts, contributions, or any questions for the speaker, you can use the chat feature. You can simply just raise your hand. We would like to get as much feedback as we can and from this presentation, so that we can collate those together and see what we can do to improve some of the issues that Dr. Gobina raised today. So the first hand I see raised here is Wesley. If you can just introduce yourself and then present your question. Over to you, Wesley.
Thank you very much. Good evening, everyone. Hope I'm heard clearly.
Yes.
My name is Buche Jache Wesley. I am currently a fifth year medical student studying here in China. I listened with a lot of interest Dr. Gobina's presentation. It was really insightful and very interesting, and I learned a lot. In regards to that, I actually have two questions. The first question is something that he mentioned at the end of his presentation. While being here in China, I received with a lot of excitement the news about the kidney transplant that was done at the Yaoundé General Hospital. So I would like to ask, I know I heard that once, and only recently while searching about the hospitals in Yaoundé, I saw a post saying that there were a number of other transplants that were performed there. So I want to know and to confirm that, okay, since that first transplant that was done and that had a lot of media coverage, whether kidney transplant is actually a reality in Cameroon right now, and whether it's something that is within the reach of, I would say, probably not the general population, but at least a middle class or higher middle class Cameroonian can be able to hope to get something like that. And also in the sense of the availability of maybe the donors and something in that sense. And the second question is, I listened with a lot of pain the presentation when hearing about all the challenges that were there from the lack of trained nephrologists, the lack of equipment and all the rest. So I would just like to ask to Dr. Gobina, as a specialist in the field, how do you see the trend going like from now, as the trend concerning both the maybe advocacy for the prevention of CKD? We know that most of the risk factors of CKD are at least preventable risk factors. And going to the diagnosis of the CKD disease, you mentioned the lack of kidney biopsy being performed in the country, and also the management of those patients. Like, how do you see the trends in all those areas? Looking at the horizon from your own point of view, do you think that there is like a reason to have hope and to be optimistic for the future in those areas? Thank you.
Over to you, Dr. Gobina.
Yes, thank you very much. I'll start with the question Dr. Samuel asked concerning the curricula. And interestingly, the head nurse in the dialysis center in Boya was doing a master's program. And I gave her this topic actually to do. She's done, defended, and also these papers should be coming out really soon. And the question was this: dialysis centers are proliferating all over the country. Are the nursing schools including any formal training for dialysis care in their curricula? That's what she went out to check, because we're using nurses in the dialysis centers. And her finding was what you will surely guess. The nursing schools have not caught up to this, not one bit. And we're not talking dialysis care in Cameroon that started 5 years ago or 10 years ago. We're looking at 4 decades, 5 decades of dialysis in Cameroon, and there is no curriculum allocated in the nursing schools in Boya, where she checked, for this. And dialysis in Boya has been since 2011. So we're going to be making a case, and we're thinking that the case will not end at just reading and sitting. A few of us need to sit together and open a training school for dialysis nurses. It's really important. I know how I battle with my nurses here in my center every now and then, but I cannot blame most of them to not have formal training. They just got sent to the center. They get training on the spot, and this is the process of training is this. When you get training, you succeed if you're very smart. You pick up 40% of what you were taught. And if you're teaching somebody, you give them maybe 5%, and they will master another percentage of what you give them. And so that everybody has to go through the same rigorous formal training, and that we are missing. So we really need to get to that. The nephrology training program is young, relatively young. I think it was opened sometime around 2012. And has been pushing out between 2 and 3 nephrologists a year. That's how we got to 30. So 30 is actually a good number compared to 5 nephrologists about 15 years ago. So we are increasing. There are at least 6 nephrologists in training right now in Yaoundé, and every year they take 1 or 2 more. We need more. We need more. The numbers are not enough. And nephrology seems to be one of those fields where we have not had much brain drain as compared to the other fields. If most of the nephrologists that have been trained in Cameroon are in Cameroon. 1 or 2 traveled out and stayed out, but so they are committed to what's happening here. We need to increase that to any degree possible. For Wesley's question about kidney transplant, yes, you are correct. Kidney transplant has not been a one-time thing in Yaoundé. A few more patients have been transplanted. And the model that is going on now is still the model of teams coming in to do the transplant and passing on skills. That the passover hasn't completed to say that the Cameroonian teams are working independently doing kidney transplants. So we are still doing periodic transplants. So after the transplant, they set a provisionally date for the next session of transplants, and they ask people to get their donors. People are doing living donor transplant, and in the absence of strict regulations, we cannot allow people to just buy somebody from the cartier. So the requirements are there has to be a family member, has to be this, there will be some checks. The embarrassing situation we're seeing is that Cameroonians are a little bit reluctant to give their kidneys. So getting donors has not been easy. And in our last meeting for the Cameroonian Society of Nephrologists, last month, we had this on the agenda, and we took a few resolutions. And one of the things we discussed was that Cameroonians love to stick to what they know. They know hemodialysis. They've heard about transplant, but they don't really believe you because they don't know what it's about. When they walk into a dialysis center, they see the man or the pa who has been there for 15 years. He's an example they want to copy. They have not yet seen an example of a kidney transplanted patient. So it's a mystery to them. And we said the SOCANEF has to sit down and tell the story of the successful transplants they've had. And the first case was a magical case. It was actually the perfect match. It was brother giving to brother. So compatibility was optimal. The guy is alive, strong, and healthy. And yes, there are plans. They are making documentaries. We're going to start to say a lot about the kidney transplant and build some steam so that people can be ready to donate. And in this phase where we're still working with the NGOs abroad and the hospitals in Geneva, it costs nothing to get the kidney transplant. You just have to come with your donor. It's free, literally. And so that's where the shock is, that people are not ready and it will not be free forever. So people should take advantage now. There's another session of matching going on, and we're gathering cases now, and we want to see more people get transplants. Concerning trends, I'm very optimistic about the trends, very, very optimistic. And I think that trends are driven by people and not by systems or organizations. We sat in a meeting, I remember sitting in a meeting, and I was just shocked that I was sitting with so many colleagues, and we're talking about peritoneal dialysis, and everybody is speaking with such, or most people were speaking with reluctance and some kind of fear. And I stopped at one point. I just asked a question to the air. My seniors were there, but I couldn't help it. And I asked that, is there any one of us here who thinks that peritoneal dialysis in Cameroon is a bad idea? Or is there a need? Everybody is d'accord that there's a need. So I've said that if we are all d'accord, how many years is it going to take us for us to engage and do it? Last year, I had the opportunity to go and get a very short exposure in a hospital that does peritoneal dialysis. That's all I needed. The exposure was very brief. It was in 4 weeks. But I came back with a resolve to start peritoneal dialysis, at least what we can offer. And I came back and recorded my first case of dialysis, peritoneal dialysis, in May 2023. And shared the story with the colleagues. And we had 1, 2, 3 more cases. We started having referrals from all over Cameroon. They are sending children. Unfortunately, some die on the way because that's not the model we should have. It's not a model of send everybody to one center. It's a model of this is possible in every center. Pick up the skill, replicate it. It takes courage, takes a lot of sacrifice. But with PD, I think that we have at least jumped that step and we're recording a success. If we can have peritoneal dialysis, kidney transplant, all of the two started in Cameroon within the space of 1-2 years, I'm very optimistic that there is somebody thinking very hard about kidney biopsy, and maybe in the next 1 year, we'll have a renal biopsy center in Cameroon. I'm very optimistic. I'm optimistic about screening. There are efforts being made to scale up screening for CKD in Cameroon. Just keep your eyes and your ears open, it is coming. I'm optimistic about advocacy, about engaging government with frank talks about what works, not what is decided of them, but what works and how we can do it. So I may be too optimistic, but Wesley, I am. I really am, and I hope that you will join us in any way possible to drive the optimism and actually do things that are working. I think that was the last question I had.
Yeah, thanks. My greatest suspicion is this is just a microcosm of the huge problem, and we are just barely scratching the surface. So I totally agree. The great need to optimize what we do have. Dr. Brunhilde Santo.
Excellent presentation, Dr. Gobina. Actually, you answered one of my questions. I have about 3 questions here for you. One of them was on PD. And I was going to ask, I mean, you kind of answered it, like the percentage of patients on PD and, how feasible it is to have it. Now, I'll also ask another question, being that I have a critical care background, and this is regarding cases in which you have maybe patients who go into acute kidney injury or even acute on chronic and then renal failure. I think there was a case in one of the town hall meetings in Bamenda where they talked about dialysis. It may have been on a child, and they had to do PD for dialysis when the patient went into renal failure. So how do you handle cases in which patients go into acute renal failure, which will happen especially if they have sepsis, septic shock, or a combination of that and nephrotoxicity from medications, traditional herbs, in general. When I in that particular session, they talked about there was lack of someone who could do a PD catheter for the patient to get PD. And from my experience, and that's what I'm asking, and I'll probably need your enlightenment. In a situation where a patient has acute renal failure in the hospital, it's easier to put in just a temporary access, just a central line, just a bigger access, and do hemodialysis than trying to do PD. So that's one of my questions. How is it approached in Cameroon? And then the other question is, and I may have missed this because I was in and out of your lecture, what's the percentage of children or maybe adolescents in Cameroon who actually end up on acute or CKD or renal failure? And what is the main reason for that? Do they have some polycystic kidney disease that was unrecognized? Because it's not common for children to just have acute renal failure. So is there a large percentage of children or adolescents who end up on that? And if so, what is the reason for that? Thank you very much.
Yeah, Dr. Gobina, I think you can.
Yes, thank you, Dr. Brunhilde, for your questions. So just to set the stage again for peritoneal dialysis in Cameroon, there is no chronic PD going on in Cameroon at all. And the challenge with that, of course, is the solutions. Even for hemodialysis, and this is where we talk about policy. Elvis was right in his calculations about how much pure water is used for dialysis. Now, the pure water is used just to make what we call the dialysate, the generator dialysis machine does that. But there's another water that we use for dialysis, obligatory. It's normal saline. Now, for every dialysis session, you use between 1 to 1.5 liters of normal saline per session. So if you're going to do 30 sessions in a day, you're using maybe 50 liters of normal saline. Common normal saline. Common normal is water with a bit of salt in it. Now, would you imagine or believe that we have so much water in Cameroon? Our National Water Agency is not able to put it in people's homes, but it is there. We know it is there. But normal saline is imported. 1 liter of water is 1 kilogram. If you use 50 liters per day, you are using 50 kilograms per day. If you are going to use 1,000 kilograms for 1 month and you put it on a ship, you are filling a container which can have 2 cars and whatever with water. And it is traveling on the seas. And it will reach the port and we will spend taxpayer money to remove water. I can understand that we will import, kidneys, which we don't make in Cameroon, the artificial kidneys and the dialysis lines, but not water. When we have societies in Cameroon that can produce normal saline, that is the problem with peritoneal dialysis, because the water for peritoneal dialysis is very particular, very special. Countries in Africa that have succeeded to do chronic peritoneal dialysis are countries that set up a production unit in the country, because it does not make sense to carry water on a ship. It doesn't. We have been doing that in Cameroon for how many decades? It don't make sense. So that's why Cameroon cannot enter chronic peritoneal dialysis. For acute peritoneal dialysis, there are studies that have shown locally made solutions that can work. And I had the privilege of meeting Professor Laila, who uses these solutions in another African country. We met face to face in a training in Yaoundé. That's where my interest was, and I'm like, this can be done. And we had studies when Dr. Palmer with the Baptist mix this solution. It's just Ringer's lactate and 50% glucose. Mix in a particular proportion, and you can use for acute dialysis. Now, you cannot use it for long-term dialysis because it's not suited. But for somebody who will do dialysis for 1-2 weeks, it's fine. You use it without any problem. So we make this solution. I make this solution locally and use it for children. So children with acute kidney injury benefit from peritoneal dialysis. But I don't take bigger children, I take younger children for simple reasons. And just trying to answer your question as well. We have adult hemodialysis machines, adult hemodialysis lines. We don't have pediatric lines. If you put a child on the adult machine, as a nephrologist, those are the cases where you don't go home. You sit beside there and you are checking parameters every 5 minutes because it's not safe. You will do it because you have no other option, because it's not adapted for children. So the bigger children who have a good body mass can afford to go on hemodialysis, so we put them. But when in my hospital, for example, since we started the peritoneal dialysis program, if a child comes and they are below 5 years of age, they come for peritoneal dialysis. So that we are able to do. We have not done peritoneal dialysis for adults, acute kidney disease in adults either, because there is hemodialysis. And the workload in peritoneal dialysis is a lot more. The fluid volumes to be consumed will be a lot more in adults. We've not had the need yet to do that for adults. So I hope decreasing. I think at some point we have had up to 15 to 20% of children on chronic dialysis. Now, these are crazy numbers. Why are they here? Polycystic kidney disease, no. I've not had any child in all my experience coming with polycystic kidney disease and coming on dialysis. Most people with polycystic disease will live with it without problems and come at a later age to start dialysis, 40 and between 40 and 50. But we think that these children, a lot of them had nephrotic syndrome, which is a type of kidney disease where your kidney function is 100%. You're just losing much proteins in your urine. It's so easy to treat, extremely easy. Yep. But people don't go for treatment. They stay in the village, they have scarifications, and an illness which can be eradicated from a child's life in 4 weeks. Majority of them are rapid response, early responders. In 4 weeks, their protein excretion is 0. If it is neglected, that proteinuria alone leaves damage on the kidney, which will bring them for dialysis after a few years. We have a good number of them. And we have a few who actually come for treatment, but they have a resistant form of it. We don't have the adapted medications to treat the resistant forms. They linger on for long with their nephrotic syndrome, and they end up with chronic glomerulonephritis, and they end up on treatment. So again, we have these children that we can help. And a lot of them, actually, the cause is unknown. It could be the medicine they have been pumping them every day since they were born. It could be the concoctions they give to everybody at home. It's so many factors. Again, it's only research that will clarify clearly what we're dealing with in terms of etiologies of kidney failure in children. Over to you, Brian.
Yeah, thanks a lot, Dr. Gobina. Do we have an idea of what the prevalence of polycystic kidney disease is in children? Do we know what the burden is in Cameroon?
Yes, so you have several types of polycystic kidney disease. The adult type is the most common type. Now, adult as in you are born with the genes, but the expression of the illness will be in adulthood. Is the most common type, whether here or anywhere else in the world. So we have a good number of adults in Cameroon on dialysis with polycystic kidney disease. Usually it's at that age that it is diagnosed. Nobody does screening for the children too early. And even when you see them when they are early on in life, you will see the cysts. But at this point, remember my early slides, you can have a structural change to your kidney, that you have normal kidney function. The kidney function will only decline later on in life when the cysts have reached a certain size, because it grows progressively. So having children on dialysis for this most common type of polycystic kidney disease is unusual. But you have other types of polycystic kidney disease, which is common in the Western world. The recessive types. These are children right from within the womb. An ultrasound will diagnose that they have this polycystic. The kidneys are already absent. You just have cysts everywhere. The children don't even live long. If we have any such cases in Cameroon, you can be sure that before they even reach the health center, they were gone. So figures for children with polycystic kidney disease are almost inexistent. They are there. They have the adult type. It will express itself at a much later age. The type which occurs in children usually is highly fatal, especially in our setting. And we will not even record those ones in the healthcare setting.
Yeah. Thanks a lot, Dr. Gobina, and also thanks a lot, Dr. Brunhilde, for the question. I hope Dr. Gobina addressed all of them. So thanks a lot. I think those were really very pertinent questions. Elvis, over to you.
Yes, Brian, thanks so much. I wanted to just have this question to Ronald. I know one of the things you mentioned was about early detection. And if you think that Muno always says that if you don't look for something, you will not find it. If you go into a program to screen people, like, and I know you did a very amazing job during the World Kidney Week. I heard you screen a lot of people in Boya for free for CKD. Now, if you identify those who are within the stages of 3 to 5, stage 3 to stage 5 or stage 4, and you know that maybe there are some medications that can slow the progression of their situation so that they don't end up in the end-stage renal disease. And we see here in the United States all the time on CNN, the advertisement on Farxiga, and we understand that there's a generic form now, the dapagliflozin, which is a generic form. My question is, I know these are very costly medication here in the West. Apart from if you screen people in the first 2-3 stage where you can talk about maybe behavioral change or lifestyle modification, checking their blood pressure, checking their diabetes. If you find those within stage 3 to stage 5, where maybe there are opportunities now for medication that can slow progression, do you have such medication in the country? And if not, how can we get this medication to your hands to prescribe to your patients? Because I remember having a dinner, and disclosure, let me put this disclosure. I'm the senior vice president in charge of global population health in a company that works on CKD. And I've actually sat with one of the vice president of population health for AstraZeneca, who is the manufacturer of this medication, and Africa is not their market, right? Like outrightly, she told me Africa is not their market. And I've been doing a lot of advocacy. That's why we've been working a lot to do population-based screening to see how much we can generate as data to show that this is a very important market for you. But just like in cancer, where Dr. Yauba has been working a lot to do price negotiation between low and middle income countries and pharmaceutical companies, is there a way you think maybe we can do the same thing that cancer is doing for chronic kidney disease, where we can negotiate these prices maybe for Cameroon at half a price, 50% the price, just to have access to this medication? Okay, it serves no, if someone needs a medication and the medication does not exist, what else do you do to the person than allow his CKD progress till the end naturally? What else? How useful would early detection even mean to this person if you don't have something you can do?
Yeah, I think it's really urgent for us to close that gap. It's really, really urgent. And in my mind, it's two ways. So price negotiations, making it available to the nephrology treating community so that they can use. And then usually medications have some kind of a solvent drug effect. The more you use, the more follows. And you end up even convincing people. I remember when erythropoietin was making entrance, all the companies selling erythropoietin had crazy prices. A lot of negotiations were done, and they realized that, in my mind, because when I see where they are now with their prices, that the degree of use compensates for what they thought they would lose by not coming to the market. A lot of people are on it, and the demand is only increasing. And because it is available, it's used for indications other than CKD and making it used as well. So some of these drugs will not come only to benefit the CKD community, because they were not even created for the CKD community, but they need to make entrance. So we need to start somewhere. And one of the areas where I always think that access is granted is when we engage into clinical trials. I sat where they were presenting some of these data, and everybody now, by regulation, FDA requires it. You must have African representation. You must have. But some of them are tricking the FDA, because FDA is convinced that the African in America is the same like the African in Africa. It's not the same. There are epigenetic factors. You know, the fact that, yes, you were born here, you lived here for 10 years, and then you moved there, your father is still in Munya, your mother is still in Ekona, you know, it doesn't mean it's the same thing. There are other factors that come into play. And so what should be validated should be testing Africans in Africa. And the proportions has to increase, because each time you see the populations that were studied, you can tell that they went to the Africans out of obligation, because it's always the smallest percentage. Like They just said a 500 people that they have to reach, they struggle to reach it. Not actually out of equity or fairness in the sense and equity that the burden is even greater here, and you want to give, a greater allocation to the area which has greater burden. So there are many other motivations behind the end point, which is the marketing of the drug. And it causes us to be left out. Then we need to try to change that. Start to bring in some of these studies, produce high quality data, and let people understand that the impact, which you think is a selling point elsewhere, is even tripled in this population. You will sell more if you show that your drug has greater impact. Because I really think some of those drugs will do more here as an overall benefit than it's having in those countries. We need to change that narrative. I'm totally on board with you, Elvis, for not just that drug, but a lot more things that are making waves and headlines out there. Talking about devices, talking about how artificial intelligence is coming in. You have handheld ultrasound devices that are changing the narratives in terms of diagnosis. We need to engage all of that for ourselves.
We had a conversation yesterday. We had a meeting with somebody who is a stakeholder in the Butterfly company that manufactures the handheld ultrasound device that can be able to help to detect chronic kidney disease too as well in terms of just the ultrasound. So a lot of innovation. Thanks for your response.
Yeah, Dr. Gobina, I know you talked about this briefly, but you talked about the mass screening initiative. I hope I'm not pulling the cat out of the box, but I'm curious what are some methods that are commonly used, particularly in Africa and in much rural settings, to assess broadly just for screening for CKD in general. What are some of those prominent tools that you've seen that are most indicative of what the underlying prevalence of kidney diseases in the population?
Yeah, thank you for the question. So I think every study that has gone towards population prevalence to me is the most valuable, because that's what actually gives you prevalence. The prevalence that the country wants to hold as its prevalence. Because the prevalence amongst diabetics and hypertensives it's a different country. It's a particular subgroup of people that doesn't represent the entire population. And so you need to look at that. And when you have that, you have the right target, which is the population, you then get the right tools. Now, remember the definition. The definition has to do with function, but also markers of disease. The most comprehensive screening has to include the marker of kidney function, which is measuring serum creatinine, but also markers of kidney disease. So you want to look at urine, and we went a little further in that everybody who was screened and had a marker of any sort, when they are coming for their reassessment in hospital, we do a kidney ultrasound for them free of charge. The majority I did that this week have never done a kidney ultrasound in their life. And I'm happy to see that, oh, my kidneys look nice and look fine. It's a life-changing experience. But that person is one of those who, that experience alone is educative, because they will not forget in the next 5, 10 years to want to check again, because they had a good feeling after this screening. Screening is important because it's so much education. I have people come to me after the screening and say, doctor, since that screening, every day now I drink 1.5 liters of water. Just because they checked my kidneys and I passed through a little bit of anxiety that I can have a kidney problem, the advice they gave me that day, I took it to heart, and I'm already applying it. People have changed lifestyles and so much just because they had an encounter over screening. So we are looking at those now, looking at different ways to deploy these tools to measure creatinine faster and better. That's where you have point of care devices coming in. Imagine you can even deploy point of care ultrasound machines, and you pick up the polycystic kidney disease right there in Akwaya. It will be life-changing because you have cut the cost and waiting time to transport that person, increase the burden of some regional hospital. You have done it right there in their community. So we are embracing everything in terms of innovations to carry some of these tools to do the right type of screening in our communities. We screen in 3 days over 500 persons in Boya. People are interested in their health. Yeah.
Thank you. Thank you. Thank you so much. I would also like to invite Dr. Victorine. I think she's also a practicing nephrologist in Cameroon. Really would like to invite your feedback on what you've seen as well in the field in your practice. But over to you, Mono, for your question or contribution.
Yeah, no, I have 2 questions. It's just, I want to get Dr. Gobina's take on these 2 things. So, Dr. Gobina, what do you think could be the solution? Because this is going to help me too in oncology, for us to be able to get our pathologists back home. We do have trained pathologists. To be able to be interested, not just in histology and cytology, but get them to the point where we can get immunohistochemistry, immunofluorescence, and the proper stainings in order to help us with making appropriate diagnosis for multiple other diseases, and even especially in cancer. If I tell you in Cameroon, there's just 1 center in Cameroon that does immunohistochemistry for a common cancer called breast cancer. You can't even get the ERPR state. If you can't do that, then it means you can't even do the basis of identifying how to treat these women. But that's going to help develop many other fields. So that's my first question. How do we get them up to par? Maybe a part B of that question is, how do we even get samples in the first place? Like diagnosis in the first place. How do we get to, are we trained enough to biopsy these samples? Trained interventional nephrologists, trained interventional radiologists, train people to be able to even biopsy me along, because if you have a lung mass in Cameroon, I had a recent case I was reviewing, a little girl with a lung mass, tissue became a very big issue because bronchoscopy could not have access to it. And this is really one of the big problems. What do you think can be a solution to this problem? My second one goes with transplant. I'm presently covering a transplant unit now, I'm on call, but it's more for after transplanting these patients that we're going to do in Cameroon, and I'm all in for innovation. Do we have programs in place where medications these patients have to take either for a brief period, for a lifetime, things like tacrolimus, things like cyclosporine, things like mycophenolate, things like isoproterenol? Are these medications, sirolimus, are these medications going to be available after this period of subvention coming in from the government or from the foreign partners? Are these patients going to be able to afford these medications, buy them, and take them? Because to me, each time I see a program being built, I always think about sustainability. How do we sustain it? Are our nephrologists being trained in transplant nephrology while the teams are coming? Because it's not just for the teams to come and go. Are they training us how to do these surgeries? Because I believe strongly, even when I left Cameroon, in case you want to do something to people, train them. Don't just come do it for fancy and leave. Are we being trained? Are we doing the efforts to get these medications available in the essential drug list? It's just my take. I just want to ask what is going on around this. Thank you.
Thank you. Thank you very much. I would start with the last question. Sustainability. Again, that's one of the areas where I'll talk about opportunity. Because a smart person is seeing the efforts being made to even start transplant, pick up the opportunity and establish yourself and meet that gap. I mean, by the time this thing is ending, and this was my cry during COVID, I'm like, we have consumed billions and there's nothing to show for it. The minimum we should have had is an infectious disease control institute in this country, minimum. with all those billions that we have eaten. There's nothing to show for it. And we need to start moving towards those kind of concrete steps. And it's also part of the answer of the first question. We need a pathology laboratory. State-of-the-art pathology laboratory. Now, it's a huge cost requirement. So people are not, that's where the courage is required to just jump and enter and start. But if you build a pathology laboratory, bring partners in, I'm sure there'll be people who are interested. And it is set up somewhere, and all you're doing is waiting for samples. You will run yourself with no problem because we are trained. Almost every nephrologist in Cameroon is trained to do kidney biopsy. A few others went and did renal pathology as a subspecialty for between 6 to 12 months. Dr. Zana, who is on the call, is trained to do kidney biopsy, to read kidney biopsy. We need a pathologist who would even cut to the size that we need and stain. And we need somebody to enter. If it's not entering through policy and government, it has to enter as a business initiative. That is where it has to go. Now, I always applaud the courage of the administration of the Yaoundé General Hospital, because I think they are doing it the right way. It must not be perfect, but we just received updates some months back. The nephrologists in the General Hospital informing us of new equipment that has arrived. They can measure drug levels. The pharmacist has stocked this medication which is required. And again, the thing is, when you start, usually it would follow. We're just hoping it's not going to end. Now, the initiative, this is the hospital pharmacy stocking, and not the organization doing the transplant, bringing a small bag of medications which they will ship again. These are opportunities. Because if for some reason, people get transplanted and they move to live in Boya and they need medication, I'm calling the pharmacy of Hôpital General Yaoundé. They have created a name for themselves. When I came to start the hemodialysis center in Boya, and the center was opened, I was the first head of center. I moved towards my pharmacy in the hospital, met the pharmacists and tell them that we are going to start receiving people of this caliber. They will need this drug. I made a list, PDF. Nothing was done. I started moving towards private pharmacy. I was not asking them for percentage. I was just mindful of the fact that I'm about to start treating dozens of Cameroonians. They will need this. They will need bicarbonate. They will need erythropoietin. The pharmacists are not interested. They love selling their malaria medication. They didn't seize the opportunity up till now. And if I had my means, or I had somebody who was smart, they would set themselves up as the nephrology pharmacy in Cameroon and give themselves the task of never running out of stock of the essential medication that we use in nephrology. All of Cameroon will turn to you when the others have run out of stock for steroids. And you have a patient with nephrotic syndrome, you're interrupting their care because there is no prednisolone anywhere in Cameroon. It has happened so many times. Ask any nephrologist. And I ask myself that, but what are the pharmacists doing? Is there a kind of money that is not good money? Or they are assuming that it will not sell? So to me, it's opportunities and the way we analyze the opportunities. I want to see biopsy started. I know Dr. Zana wants to see biopsy started. It takes of courage and organization. And if government is not doing it, let us find a way and open a private place. Get the right things present in that place and get it running. For kidney biopsies, we can do. I don't know about lung biopsy and what kind of training is required, but we need to start something. I think that we can find solutions.
Thank you.
I think for lung biopsies, I think I can speak for that because I do some of the procedures. I think you will probably one of the things you need is equipment. And then before training even. So depending on, you could have procedures as simple as just a simple bronchoscopy, which could be limited in a way because unless you have a mass that is growing into the airway, you may not be able to do biopsies. But nowadays, you have other procedures, like EBUS and the bronchial ultrasound, which you can use for staging as well, especially if they have lymph nodes. And then you have some other, navigational bronchoscopy, radial bronchoscopy. So I think it will boil down to even having the equipment, and people are even able to do bronchoscopies. So I think from the long standpoint, that's what I can add.
Yeah. So yeah, what I want to say is just it's more of, it's a field where interventional training should be done in most internal medicine fields, and then the training also of interventional radiologists, which I think we do have some back home in Cameroon, but equipments are lacking, training is also lacking, and opportunities are maybe lacking. But it's a field that is going to help progress multiple analysis for tissue biopsies that are needed for multiple organs, including renal, which nephrologists are trained in Cameroon, and also reinforcing pathology. I do know of a pathologist in Cameroon who did actually renal pathology. He was in La Cantini, but he just moved to the US. I think that is Bellinger did some, I think 2 years with renal pathology. And there may be others. Cameroon's problems are sometimes you need advocacy from the specialists themselves, who would want to advocate for the government to actually take this thing seriously and get to equip some of those hospitals and get us interested. So thank you very much.
Yeah, thanks a lot for bringing that up. I totally agree with the need. I wanted to invite Dr. Cedric Xavier and also Dr. Zana. I don't know if she's still on. I really would love to welcome your feedback as well as your thoughts as well in terms of what you've seen in the field, where the greatest needs are and where you see the greatest opportunities. Dr. Xavier and Dr. Zana.
Hello, everyone.
Yes, we can hear you. Yes.
Yeah. Thank you for giving me this opportunity to share with you my thought. Thank you, Dr. Gobina, for painting the picture clear as it is. He just hit the right button. He has said nearly everything. So far, in terms of training, as you know, the know-how is available. But now, probably most of the time, what we lack might be the facilities. The facilities might not be available at the right time. Taking, for instance, like renal histology. We have many nephrologists that are trained, like he rightly said, in reading biopsies, and but now we don't get somebody to do the technique. Dr. Bellinger was there. He did one or two, some few. He was trained. Probably the thing is where the interest lies, because most pathologists would prefer to do pathology for other illnesses, but not kidney, because they just need, as he rightly said when he was comparing renal pathology to pathology of maybe other like malignancies, because to them it's easy. It's easy. It just takes online microscopy. They just want to see the number of cells. You want to see this. They can interpret several light microscopy for maybe malignancy or tuberculosis or whatever in less than no time. But when it comes to renal pathology, the size of the slide is more. It's sometimes a bit difficult to get, especially the appropriate thickness, because when you cannot do that, it's very difficult to read, and even the procedure. This makes it very difficult for most people to do it, because they are like, okay, I could just do 10, 20 pathology reading and I get the money, whereas renal pathology might take me a longer time. and not only taking a longer time to get the result, but at the same time, many people will not be able to pay for it, because when we started, it was more like trying to subsidize, and I'm sure that's what made many of the pathologists to lose interest in it. And again, there's still hope. Sometimes even those who are willing to do cannot get simple stainings. I don't know whether it's because it's expensive or just because since the hospitals, most hospitals don't maybe see how policy leaders want to see what they are gained and everything. Maybe they don't see it as very profitable, so they don't get to invest in that. What else? With regards to kidney transplantation, as Dr. Gobina rightly said, the General Hospital, Yaoundé General Hospital, is doing a lot. And it was a very bold step. We know it's true, we have not yet really thought about maybe in the nearby future, what happens to if the program doesn't, it's not still viable, like medication and all whatnot. But until now, until the next few years, I think they are up to the task, and they are for the medications, and they have tried looking for alternative means of getting those medications. And one more thing, those trainers who come in, they don't just do the surgery alone. It's like a teamwork, because we have vascular surgeons here in Cameroon and urologists who are also actively involved. And from time to time, they go to Geneva too. So it's like a cross program. So I think the capacity building is ongoing, and very soon the center will be independent, fully independent. We still have a lot to do, but we are very optimistic, as Dr. Gobina said, very, very optimistic. And we hope in some few years, the nephrology in Cameroon will have a better face. Thank you.
Yeah, thanks a lot, Dr. Zana. Can you remind us which hospital you're working with, you're currently affiliated with?
Yeah, I'm at the Yaoundé Central Hospital. Then I do part-time at the CHU, the Yaoundé University Teaching Hospital. I'm a lecturer too with the Faculty of Medicine and Biomedical Science, senior lecturer.
Yeah, thanks a lot, Dr. Zana, and thanks a lot too for all the work that you're currently doing. So I think we are close to the end for today. I do see there's one last hand up. Elvis, if you'll permit me, we can, if anyone can make your question or contribution really very brief, since we are really running short on time, so we can close and then we can move on to the parking lot. Anyone?
Hi, thanks everyone. It's such a great pleasure for me to be part of this meeting, and as a clinical trialist by training, I'm mostly here to advocate a little more on that aspect. I think recently there was a competitor to Fasiga that wanted to run a trial in Cameroon, but because we lacked pathology and biopsy opportunities, and this study could not move forward. And this was an opportunity for Cameroonians to have an opportunity to be to have such medication, which is not really available for them, but because of the lack of such facilities, and we could not be able to run such studies in Cameroon. When I was in Roche Genentech, I used to work there. Cameroon was in red for the countries they cannot do studies in. I'm currently at Merck. Cameroon is still in red, but the countries they cannot do studies in. So they classify them in colors. We are not even close to the pink or yellowish or somewhere close to where we can do some clinical studies. And I feel like these opportunities can really help Cameroonians get access to medications that they need. And we can really get real data on how Cameroonians respond to some of this treatment over just using it when the drug is made available by the FDA or something. So I just wanted to thank Dr. Ronald for for what he has done, and just encourage some of the team members that we have here that we could it's important for us to forge ahead in really establishing some of these institutions in Cameroon. Thank you.
Yeah, thanks a lot, Emmy. I don't know, Elvis, I know you're also an expert. You're also forging for clinical trials across the continent in Africa as well. Any thoughts on this? I didn't know that based on Roche data and Merck data, Cameroon has been on red all these years. What are your thoughts on how we can mitigate some of those? You're muted, yeah.
Yeah, thank you so much, Fund, for your comments. Really highly appreciated, and we look forward to really having more conversation with you. And maybe sometimes, if you are happy to come be a speaker on the town hall, just to share some of the checklist for the criteria that Merck or any of the companies you've worked with in the past use as a criteria to classify some countries as high risk, or maybe red or yellow or green. But I know in my work in clinical trial, and I consult for the Bill and Melinda Gates Foundation, where we review a lot of protocols that are done for clinical trials that are done in Africa. And we have a kind of assessment tool they call the best practices for clinical trials informativeness. And one of them is disease burden, right? But that's all we can boast of. We boast of the fact that we have the disease burden, but disease burden is just one of the best practices for choosing a clinical trial site. But there are lots of other things that go into play for choosing a clinical trial site. And if you are to run a trial that has to do with a lot of histology and there are no histology labs in the country, and then that becomes a red zone. If you are going to do a clinical trial and you need a lot of research nurses, and in the country there are no research nurses, then that's a red zone. If you have to do a trial where you need a lot of research pharmacists and there are no research pharmacists in the countries that you can actually boast of, then that's a red zone. So there are so many different things that come to give, a site, because of course, if there's a clinical trial, it means there's a research site that has to be accredited. So there's so many things for site certification to see that that site meets a criteria to be a research site. So I think we need to continuously advocate and work hard. But I think that there are so many great researchers in Cameroon, and there are so many senior scientists in Cameroon that I know of. I think the only thing that we need to do is really get more organized in the way we do things. In so much of my experience with Cameroon there's been so much of silo work. Each researcher want to form their separate colonies, but I think this is high time researchers need to talk to each other and build coalition, because most of clinical trials grants now are gotten when researchers come together and build a certain coalition and bring expertise. Because one of the best practices of also informative clinical trials is using those with experience in the disease area that you are researching. So if you are researching on cancer, you want to have a clinical trialist that has an oncology background and experience. If you are researching on malaria, you want to have a clinical trialist that has a research on parasitic infections and all, So I think it's really an important thing Annie has told us today, which we need to also bring him forth to talk to us to see how we can prepare Cameroon to be an attractive site for clinical trial, which just come to add to the effort which we have been doing when it comes to just reviewing clinical trial protocols to make sure that African researchers get their protocols really highly favored when it comes to donors and funders of clinical trials. But I think any fund is talking about it, Cameroon being a clinical trial site, which is a little bit, different from the work that we are doing to encourage African scientists to conduct clinical trials. But I think our work can intersect at some point. I would like to hear him further on the town hall. Thank you so much, Annie, for your contribution.
Yeah, thanks a lot, and Elvis, and Emmy, that's also an open call for you. Would love to hear more about that, and particularly what we can do in Cameroon. I think there's a huge need for us to really build a robust electronic disease surveillance system, so we can really have the ability to quantify what the burden of disease is in across health facilities in Cameroon. I think that need is definitely pressing. So I just wanted to round up with everything. And again, thanks a lot, Dr. Gobina. I will just want to take a last round with my other moderators here today. I think this was a really interesting conversation. And based on, I see your hand is up, but we would love to take your feedback into the parking lot when where we can discuss afterwards on further on this topic. So I think I'll start with Dr. Mono. I just want to get some closing remarks, and then Elvis, and then we'd like to get some final words from Dr. Gobina. Dr. Mono.
Yeah, thank you, Brian. I think this was very informative. I learned a lot. It was a masterclass presentation. I think there's room for improvement back home. There's always room for improvement. Even here in the US, I can tell you that. Room for improvement everywhere. So at the end of this presentation, my take-home message is that there's a lot going on. The government has invested a lot, both in human resource and also material-wise, and we can do dialysis in all the 10 regions. Now we're moving towards transplanting patients, but we need to be able to diagnose them. You can't transplant people or treat people that you cannot make diagnosis on them. So pathology becomes a very important field, which I've always said. Even in cancer treatment where people feel comfortable, we have passed the stage of saying something is an adeno or a squamous. That's not what we say anymore, because at first chemotherapy could work for everyone. Maybe the pathologists were comfortable saying that, but immunohistochemistry is the key to identifying where the cancer is coming from. If you don't know, if someone didn't tell you before it was esophageal cancer, they were biopsying, or lung cancer, they were biopsying. So it just says adeno and tells you it's coming from this. So we need to, if we invest in pathology, that's going to help every other specialty. I'm not presently a pathologist, but I know if you invest in pathology, it's going to help every specialty. If every single physician who is trained, not only a nephrologist, knows that when they do little surgery, they should send it out for pathology diagnosis. There are pathologists that are subspecialized in GI pathology. Nephrology pathology is a subspecialty, like you have in internal medicine. Neuropathology is a subspecialty. Lung pathology is a subspecialty. Surgical pathology is a subspecialty. Histoimmunochemistry is even a subspecialty. So it gets to a point telling you that there is still a lot to do. And Brian, my last take-home message is always the auxiliary care that helps us physicians build. Cameroon is very good at building physician capacity and forgetting to build capacity for nurses, for technicians, for other technicians that would help us build. So rather than proliferating medical schools, we should start proliferating these other schools that would help build others that will make us practice better medicine in Cameroon. That's just been my advocacy. I want to thank Gobina for his time, for the short notice, for the wonderful presentation. And he has always been a leader that we have always looked up to since the time in medical school. So congratulations and courage in what you're doing. We're always admiring you from afar, from near, and everywhere. So keep doing what you're doing with the different foundations that you're engaged in. So with the advocacy and policy. So I know you do a lot of work there. So thank you very much.
Thank you.
Elvis.
Yeah, thank you, Brian. Dr. Gobina is one of those experts back home that I hold with high esteem. He is one of those persons that when you call and say you have a program that will benefit patients, he will abandon everything that he will do to make sure that that program works. So I can attest to that based on experience on the things we've done together. I want to say that thank you so much for accepting our invitation. Your presentation has really been a great presentation, and I would play this over and over. And to all those who are attending the Cameroon Town Hall for the first time, we always record these presentations and host it on our YouTube channel so you can have access to it. It's really been a great presentation to me because, of course, I'm doing a lot of work in the CKD space. I've learned a lot from you because I'm not a nephrologist and my knowledge in this sector is limited, but I really learned a lot from you. But Brian, like I mentioned before the presentation started, I was really interested to know about what he would say when it comes to drivers, the key drivers of CKD in Cameroon. And Gobina said 46% that we are witnessing or postulating that will be kind of 46% increase in the diabetic prevalence by 2045. This is huge. This is really huge. And if diabetes is one of the risk factors of CKD, and for hypertension, he said we are witnessing a kind of 1 in 3 adults worldwide with hypertension. That's what is projected to happen and is happening. And we also had risk factors like hepatitis and HIV. Don't forget, hepatitis C prevalence in Cameroon ranges between 10 to 13. And so if we have these other silent, risk factors, then it really compounds the entire problem of CKD in Cameroon. He also talked about the issue of obesity, and we have about 1 in 5 women or men by 2030 who are going to be obese in Cameroon and in other parts of Africa. But what caught my attention was his comment on non-traditional risk factors. And he said that, what is called non-traditional in the West is traditional to us. These are risk factors that concern us as Africans. One of them that caught my attention is the use of traditional medications, herbs. When somebody has typhoid, you go cut all the herbs outside, boil them, drink at any proportion you want. Those are the things that are causing these kidney problems that he's seeing every day. And I have a friend who's lost a wife because the wife went on a weight loss regime and drank a lot of concoction and got the kidney and liver all fired up in less than 3 months. Those are the kinds of patients that Ronald is seeing every day. So I think that, Ronald, there is also a committee or in the Ministry of Health that has to do with traditional medicine. And I don't know if there is any way that the National Society of Nephrologists in Cameroon can partner or just have a conversation with the traditional herbalists that have a department in the Ministry of Public Health, so that there should be a conversation around the impact of their concoctions and how it plays on this increasing number of CKDs that you are seeing. And if we can start having a dialogue up around quantification and maybe dosage of traditional medication, so that we can start solving this problem with those who practice it the most, and they have a well-organized structure that is embedded in the Ministry of Public Health. I think, Brian, this is all I took home, and I think there is a lot more that we have all learned from Ronald. All I want to say is thank you so much for your time and for the work you are doing to help Cameroonians.
Thanks a lot, Alice, for that great recap. I wanted to give the final word to Dr. Gobina. Again, thanks a lot for your leadership and continuing to be a model for us young people and young other medical students in Cameroon. Really admire your work and thanks a lot. So final words to you, Dr. Gobina.
It was such an honor to be here. Thank you for the opportunity. I think that the session has recorded some gains in the fight against CKD progression, and that's my intention. And just from the questions, I'm seeing potential partners to engage diverse actions, because we need to keep the energy going, not slacking down. There's a lot to do, and we can do it cross-field, nephrology, oncology, all of it driving the health of Cameroonians counts me in. So thank you all very much.
Thank you. Over to you, Elvis.
I think, Brian, that is all. For all those who join us today, we apologize. We sent an email to inform you that there was a daylight saving, and so the time for Cameroonians now is 6 p.m., not 7 p.m. So we look forward meeting you in our next session of the Cameroon Town Hall, whose time is going to be 6 p.m. in Cameroon and 1 p.m. Eastern Time. This meeting takes place every fortnight, so in 2 weeks' time, we're going to meet yet for another very exciting session of the Cameroon Town Hall for Healthcare Professionals. So thank you so much for attending, and see you in 2 weeks.